for connecting. It was a great pleasure to create this webinar in collaboration with Dr. Marco Guidi and the special guest, given the rehabilitation imprint of this webinar of Shrikant Chinchalkar. And we have received registration from all over the world, and this honors us very much. But let's not waste time. The webinar has changed order to facilitate the usability. We started with the Shrikant Chinchalkar, then the Ergomano, and the last but not least, Dr. Marco Guidi.
Thank you. Good evening, everybody.
So first of all, good afternoon, everyone. Before I begin, I would like to sincerely thank Dr. Marco Guidi and the therapist from Ergomano Rehab from Switzerland for giving me this opportunity to present on midcarpal instability. Every day we face with many challenges, and midcarpal instability is another one. So I would like to disclose that I had a professional relationship in the past with North Coast Medical. So looking at the midcarpal instability, we know that it could be classified as extrinsic or intrinsic. Any bony pathology involving radius or ulna, the instability produced distally could be grouped as extrinsic category. As you can see this cadaver dissection in our biomechanics lab, you're looking at how carpal changes its orientation when you move the wrist from radial deviation to ulnar deviation and vice versa. So looking at the midcarpal instability, we know that it is divided into purely dorsal, palmar, or a combination of both depending on in which direction the carpal subluxation is occurring. Capitolunate instability pattern or CLIP, or complex carpal instabilities, these are the common examples. So what we are looking at, we see that the distal radioulnar and carpal orientation is somewhat altered. Often you will see that there is a carpal sag on the ulnar side. The carpus is pronated, and of course there is a misalignment. If you look at the distal radioulnar relationship in relation to the carpus, there is an oblique orientation of these two. So in other words, the carpals are in supinated position, they are rotated somewhat and are sitting in an inclined position in relation to the distal radioulnar joint. So subsequently, you can very well imagine, based on the anatomy of the ligamentous structures, the dorsal radiocarpal ligament and dorsal intercarpal ligament are somewhat tension, causing an ulnar sided wrist pain. Whereas on the volar side, you will see that because of the ulnar sag, you will see ulnolunate and ulnotriquetral ligaments somewhat slack, producing an abnormal tension on the radial arm ligamentous structure. So in other words, the whole entire carpus is deranged in relation to the distal radioulnar joint, and that produces an instability pattern. So this midcarpal instability was first identified by Lichtman back in 1980, who found that there is a volar sag on the ulnar side of the wrist joint, and patients often had complaints of painful clunk. And he attributed that to the ligamentous laxity of proximal as well as midcarpal ligaments. It was obvious that palmar midcarpal or volar midcarpal instability is quite common, and of course they fell into a SIND carpal instability non-dissociative category. And the instability therefore was attributed to the disruption of the ring concept. So obviously on visual examination it appears abnormal that there is a palmar sag of the ulnar carpus, and you can see that the ulnar styloid appears quite prominent, suggesting that there is probably drudge instability. And because of abnormal orientation of the carpus in relation to the distal radioulnar joint, and as I mentioned earlier, that Dorsal radiocarpal ligament is often tension. Patients often have pain or complaints of pain and tenderness on triquetrohamate joint. So if you look at when we ask the patient to perform motion going from radial to ulnar deviation and vice versa, we see that the smooth gliding of intraocular motion of the proximal carpal row is disrupted. In other words, the synchronous motion between the distal and proximal carpal row doesn't happen as it should because of the ulnar sag. However, if you look at the fluoroscopy of these individuals, you'll often see that the proximal carpal row begins in a VZ position. VZ stands for volar intercalated segmental instability. And when you go from radial to ulnar deviation, the catch-up clunk disappears. So Lichtman graded this in 5 different categories. And of course, this was modified by Hargrave grading, which also has the 5 different categories. And of course, they have categorized in terms of the description as to what exactly happens, going from pre-symptomatic to dynamic and so on. So it's very important for us to consider how much sag does a patient represent or show. Can we really quantify that? Maybe to some degree, we can look at the angle between the distal radial ulnar joint alignment and inclined carpus. And of course, we can measure this inclination in terms of degrees. And of course, we can keep on using this method of evaluation on an ongoing basis as we treat these individuals by conservative means. Whereas PC Ho, Dr. Ho from Hong Kong suggested that we also must look at the distance from ulnar head to the orientation of the carpus on the volar side. So these are the objective measures we can keep recording on an ongoing basis. And this is of course my wrist, and we can very well see that if I don't have a clunk as you can see right here, but if the patient has a clunk and the catch-up clunk sort of disappears, we can identify or quantify whether the sag reduces by how much after the catch-up clunk has occurred. So interestingly, when we do a clinical examination, we can very well see that patients often present us with painful clunk. An observation, visual observation definitely demonstrates that the patients have a palmar sag. And I had mentioned that earlier, that it appears like a drudge dislocation. So when we perform radioulnar motion, the palmar sag disappears with catch-up clunk. And then in such situations, mid-carpal shift is definitely suggestive of clunk associated with pain. So the specimen or individual on the right-hand video, it shows that the catch-up clunk occurs. But very interestingly, the catch-up clunk is quite prominent, especially when the forearm is in a pronated position. The video that you see here, this video is a midcarpal instability. It's a clip capitolunate instability pattern. So on clinical examination, when forearm is in a pronated position, when the person performs radioulnar motion, the clunk occurs. And we talked about as to why this occurs, because obviously there is an abnormal orientation of the carpus in relation to the distal radioulnar joint. So here, of course, the carpus is in a supinated position. You can see that this carpus definitely is not going to have any synchronous motion because of oblique orientation of the carpus in relation to the distal radioulnar joint. I know I'm repeating that over and over again, but for a reason, because I want to establish the thorough understanding of the carpal instability that we often see with these cases. So we looked at quite a number of our cases, and while examining them, it was apparent that they did not have any carpal clunk when the forearm is in a supinated position, and I always wondered why. So obviously having an in-depth discussion with Dr. Garcia Elias, upon looking at this no clunk business with forearm in a supinated position, we know that the carpus is aligned with the distal radioulnar joint. And in addition to that, because the carpus is in aligned with distal radioulnar joint, the ulno-lunate and ulno-triquetral ligament are optimally or normally tensioned. So as a result, combination of both these provided adequate amount of stability to the carpus over the distal radioulnar joint, and therefore we concluded that there is no clunk visible or noticeable, especially when the forearm is in a supinated position. And interestingly, we use this concept while treating these individuals, and I'll come to that as to what we decide. On physical examination, of course, you can look at some provocative test in order to find out the instability pattern, as you can see, or as it is demonstrated right here. So besides that, we normally keep a log of their pain on visual analog scale. We look at whether they have pain at rest and how much, whether they have pain with motion or hand usage. And we keep a critical record of that right from the beginning as we are starting the treatment, and then we identify whether this, as the catch-up clunk, this starts to disappear and the carpus starts to come in normal orientation in relation to the distal radioulnar joint, whether the pain reduces. So this is an excellent example for us to look at. So from the management point of view, we know the midcarpal instability can be managed conservatively. And of course, it can be managed surgically if conservative management fails. So here my focus is mainly on conservative management, whereas Dr. Guidi is going to focus on surgical management of midcarpal instability. So conservative management especially is by prescribing patients with NSAIDs to minimize inflammatory process, that is as a result of abnormal clunking of various carpal bones causing an inflammatory response. However, it's very important for us to focus on patient education. We need to educate these patients how they can modify certain activity in order to minimize clunking. But the main concept is basically looking at orthotic consideration, which is always in a form of pisiform boost concept, and then going on to dynamic wrist stabilization with active muscle contraction. But all these wrist patients or any joint involved patients definitely require proprioceptive training during their treatment periods. So my focus is going to be mainly on orthotic consideration, that is based on pisiform boost concept, and looking at the dynamic wrist stabilization with active muscle contraction, and of course I'll be discussing briefly on proprioceptive training as well. So my management is based on Hargreaves grading system of Palmer midcarpal instability in a VZ form. So if you look at grade 0, 1, and 2, these three categories of instability will definitely respond well or better to the conservative management that we use in our clinical setting. However, the stage 3 or grade 3 static reducible may respond to conservative management or may not, and whereas grade 4 is definitely, patients often show the fixed VZ deformity, which is not easily reducible and it's in a locked position. They may respond somewhat to some degree, but definitely they are the surgical candidates. So we'll focus on the splinting consideration first and then go on to the strengthening and proprioceptive training. So the primary management or goal of management is to reduce ulnar sag by splinting. As you can see right here, by applying a boost at the pisiform bone dorsally, we can see that the carpus reduces. And this is the splint design that was introduced by some authors in the past. However, I personally do not favor this for a reason, because this splint is quite uncomfortable at the level of ulnar head due to the material rigidity and possibility of skin breakdown and giving us skin irritation and so on. So having used this splint in patients often complaining about the discomfort, we came up with this particular splint design. So we make two splints. One is the forearm base splint as well as palmar base splint, and apply a Velcro and pull the Velcro in a dorsal region so that we can realign the carpus in relation to the distal radioulnar joint. So our finding has been that ulnar carpus boost orthosis by applying the forces dorsally definitely reduces the ulnar sag and reorientates the carpal bones in line with the distal radioulnar joint. But that's not sufficient. Patient definitely will require the activity modification and ECU strengthening exercises. However, at our facility, we often, upon applying various kinds of splints or different types of splints, we often will assess them fluoroscopically to ensure that the orientation of the carpus is well achieved by means of splinting, and patients have no clunking whatsoever by positioning the carpus in line with the distal radioulnar joint. So starting off with the rigid splint, we'll then go on to using a PC form boost taping technique. Now, this is always initiated with forearm in a supinated position. This is based on our fluoroscopic examination that when the forearm is in a supinated position, then there is no clunk. So by applying this tape, starting from the forearm in a supinated position, applying a dorsal load, as you can see right there, it sort of realigns the carpus in line with the distal radioulnar joint. And of course, we secure that by using athletic tape, maintaining the carpus orientation. And then fluoroscopically, we have looked at these patients, making sure that when you're transitioning from the rigid splint to the taping technique, that there is still not adequate, no clunk whatsoever when the taping technique is used. So now, of course, sometimes the tape may be causing an irritation to the skin. So instead of that, you can use a neoprene strip in a similar manner and apply with the Velcro so that there is no skin irritation produced by the adhesive that is often on this tape. So again, I'm emphasizing that after applying this splint or a tape, we often look at the fluoroscopy to ensure that the orientation is proper and there is no clunk apparently available or visible fluoroscopically. So this is the neoprene commercially made splint that you can buy or purchase from North Coast Medical. However, there are homemade devices that you can use in order to provide the carpal stability, especially using various techniques. So as I mentioned earlier, that the carpus is better oriented when the forearm is in supination. So whenever I'm starting to train these patients with wrist stabilization exercises, we always begin with forearm initially in a supinated position, because the gravity itself aligns the carpus in line with the distal radioulnar joint. And in addition to that, there is an optimum tension of ulno-lunate and ulno-triquetral ligament. And then this strengthening definitely helps maintaining the carpus in proper alignment in relation to the distal radioulnar joint. So based on some of the work done by Maria Esplugas from Spain, she has shown that voluntary contraction of hypothenar muscles in supination, initially starting off with isometric exercises, then progressing to active ECU and FCU, strengthening over time, will give patients better stability and better reduction or better reorientation of the carpus in relation to the drudge. For quite some time, we minimize or reduce or recommend these patients not to perform radial ulnar motions. It's often a tendency of these patients to look at whether they have clunking or no clunking, and then they'll prematurely start moving the wrist without any devices in radial ulnar and may fall back in the same position again. So studies done by, again, Maria has shown that ECU contraction causes ECU contraction causes midcarpal pronation. And by activating extensor carpi ulnaris, it helps in stabilizing the wrist with ulnar-sided ligamental deficiency, causing tightening of the triquetrum and distal carpal row ligaments. And then activation of flexor carpi ulnaris definitely also produces extension of the proximal carpal row, aligning that with the distal carpal row. And this, according to Maria, proprioceptive reeducation of these FCU and ECU definitely plays a major role or important role in regaining dynamic in the treatment of carpal instability and regaining dynamic stability of the carpal bones when you activate flexor carpi ulnaris and extensor carpi ulnaris together. So diagrammatically, they have identified that when you perform flexion, especially in a resisted manner, the flexor carpi ulnaris produces a pressure on pisiform, because pisiform is embedded in FCU that produces a load on the triquetrum, causing the triquetrum or proximal carpal row to align in extension rather than remaining in the VZ position. So this is the work done by Harwood. This paper is published in 2016 in European volume of hand surgery, and he has also shown that various advantageous motion can be done by means of strengthening flexor carpi ulnaris and hypotenuse muscle groups. So special activation of targeted muscle is flexor carpi ulnaris, which helps in dorsally directed forces, which induces extension of the proximal carpal row and not allowing it to sit or remain in a VZ position. Whereas ECU is a carpal pronator, and this also helps with the lunate and triquetrum and its orientation. In combination of both FCU and ECU strengthening definitely causes dorsally directed pressure on the ulnar side of the wrist, reorientating the carpus. So these are the targeted muscle contraction for volar midcarpal instability patterns. So from supination, then we go on to bringing the wrist in neutral position. And in neutral, again, we want to re-establish the orientation of the carpus in relation to the vertical orientation of the distal radioulnar. Now you may ask as to why forearm in neutral position. And the reason being, if you look at the forearm muscles that originate from medial and lateral epicondyle, we can see that both these muscles that are originating from medial and lateral epicondyle have an optimum length tension relationship. In addition to that, the dorsal and volar radial ligaments have an equal length, and subsequently these ligaments having equal length definitely influences the dorsal radiocarpal and dorsal intracarpal ligament, along with the volar ligament, volar radial ligament being optimally taut. It produces optimization of tension between ulno-lunate and ulno-triquetral ligament, and therefore these structures help in retaining intrinsic balancing, creating a balancing act at the ulnar side of the carpus. And then some of the mechanical studies have definitely shown that the muscles therefore have a greatest strength output when forearm is in a pronated position, and therefore we are now using the optimum length tension relationship of all these structures, that is ligaments, as well as the muscles, producing optimum tension, maintaining the stability of the radioulnar as well as the carpal bones and their relationship. So this is the reason why we use the forearm neutral, going from supination to neutral, and then of course we want to transition from supination to neutral, and then from neutral to pronation, because we know and we have seen that when the forearm is in a pronated position, this often was the real culprit in producing midcarpal instability. So our management is proprioceptive training, going from supination to mid-prone and then pronation, and our treatment is voluntary contraction of, again, hypothenar muscles in supination, starting off with isometric, going on to active ECU and FCU strengthening program. For quite some time, we minimize or reduce patients or not allow these patients to perform any radioulnar motion until we objectively identify that the carpus is starting to reorientate in relation to the distal radioulnar joint. It's quite likely that the patients may require splinting for longer periods of time, longer than 12 weeks period of time in certain situations. And we have seen that some patients required the splinting or taping, for that matter, or neoprene splinting for a period of about 6 months and so. So wrist stabilization now transition into pronation. We continue with the proprioceptive training in this position. We continue with ECU strengthening, especially, and then gradual increment of radioulnar motion with the wrist hinge splint. So we identify at what level of radioulnar motion patients often demonstrate the clunk, especially at this level. And then after we have provided these patients with the wrist hinge splint, we'll progress these patients to certain functional tasks and then go on to strengthening over time. And then patients may require ulnar boost. At this stage, I may not use ulnar boost taping. However, I'll introduce patients to the ulnar boost neoprene taping rather than adhesive taping. So these are the custom wrist hinge splint. You can see that we can custom tailor the amount of ulnar deviation and radial deviation. And we want to allow some motion of radioulnar motion. However, we do not want to allow the clunk to happen. So therefore, we can control the amount of motion within the limits of this wrist motion by using the graded or graduated wrist hinge device. And of course, this is for the capitolunate instability. As you can see that we can custom limit the motion that is aggravation or aggravative causing instability of the wrist joint. So results are quite encouraging, especially when we manage these patients conservatively. These are one of our physiatrists who had quite a bit of clunk, as you can see right here, which is apparent, and then fluoroscopically it's obvious that the clunk is causing quite a bit of pain and discomfort. And this is the patient after about a year who used ulnar booster splint, and of course with proprioceptive training, she has no clunk and of course lesser amount of pain. So this is at 1 year follow-up. So there are a number of studies which have mentioned that there are long-term functional results with the wrist exercise program for patients with palmar instability. So this is a paper that was published in Journal of Wrist Surgery back in 2018. I would like to draw your attention to this paper. And their conclusion was, although palmar midcarpal instability remains to be a chronic problem, the wrist exercise program is promising with acceptable functional results and providing these patients with good quality of life. The other paper that I'm quoting here is by Mart Brands. Again, both these papers I think are from Netherlands, and they have concluded that by using the exercise program for patients with dorsal or volar palmar laxity, they treated 213 patients, and they identified that 78% of the participants did not require any surgical intervention. You can imagine that 78% success rate was achieved through the management, conservative management. So if you go on LinkedIn, you'll see that there is a posting by Rehand, and they've described how to diagnose and treat palmar instability. And I would recommend that you refer to this as well for your own interest and use these methods of management clinically in your clinical setting. So in conclusion, midcarpal instability could be a disabling condition if we don't know the causative factors, and especially because they fall into a SIND category, carpal instability non-dissociative. Often a wrong diagnosis is established, and patients often are referred for grip strengthening or aggressive strengthening without even given a thought, and as a result, these patients end up having premature degeneration of radiocarpal and midcarpal joint, especially ending up with partial, if not full fusion at some point. So I would say that patients with midcarpal instability definitely can improve with customized ulnar boost splinting and a prescribed exercise program. I must emphasize that proprioceptive training is a must and should be incorporated with the above in order for us to regain strength or improve strength, improve muscle control and the control of the wrist and carpal bones and coordination using these wrist muscles. And I will emphasize that positioning of the forearm during splinting and strengthening is the key so that we can reorientate the carpals with distal radioulnar joint and re-establish relationship between these two structures. And we can say that conservative non-invasive management especially is effective in many conditions, and if it fails, of course, patients are in the hands of doctor or the surgeon or Dr. Guidi for the management surgically. Thank you very much. And here is my email address, and if you have any questions, you can either ask me now or maybe later on. If you think of any, you can send me the email and I'll be delighted to answer your question. Thank you very much.
Thank you very much, Shrikant, for your presentation. It's very useful in our practice. And now we start with a case. Okay, so now we start with a case report about our recent experience. And is a girl, and she has 20 years old. She has bone trauma on October 2022. She has diffuse pain in the left part of wrist, and she had a visit to a hand surgeon just on June 2023. And she's a dancer in her free time and arrived at our practice in July 2023. She had a small fissure radius slope of TFCC and a severe ligamentous laxity with a Bateson scale. And this is viewed on MRI by the standing surgeon. But despite the ulnar pain, the surgeon sent us the patient as midcarpal instability. The patient showed us ulnar green test positive. Then we started with the visual assessment, which showed the obvious mediocarpal laxity at the palmar shift to start a differential evaluation from TSCC, confirming the surgeon point of view about, and the end catch-up clunk test positive. To complete the intake and the functional assessment, the patient presented a weakly positive scaphoulonate laxity with a Watson test slightly positive.
Based on the current literature, our protocol included avoiding and modifying aggravating activities by starting with a period of splinting. We begin proprioceptive sensitization early within a pain-free range of motion. Then we proceed to conscious neuromuscular rehabilitation, focusing on quality and control of movement. We begin with small, isolated and isometric movements to teach the patient cognitive control of joint and muscles. Next, we begin unconscious neuromuscular rehabilitation, However, the goal is pain-free stability, not necessarily the full range of motion. We started by educating the patient to avoid aggravating the activity that caused the pain, click, and clank. So during the dance workout, the patient avoids push-up with the palm resting on the floor, and she replaced them with support on the fists. The patient used the thermoplastic ulnar blue splint for 6 weeks, day and night, and then the neoprene one during the dance class. Immediately, we begin perception exercises that include training the sensation of joint movement and the joint position sense. Kinesthesia is the ability to sense motion of a joint, and to train it, the therapist passively moves the patient's wrist in one direction. I ask the patient to indicate when she feels the wrist moving. It's best to do this exercise with eyes closed to eliminate the visual clues. Joint position sense is, according to Dr. Hager, the ability to accurately produce a specific angle. To train it, the affected wrist is positioned by therapist, and the patient attempts to move the injured wrist into the same position as the affected wrist, with the vision occluded. And finally, we use mirror therapy because it provides benefit to improved coordination, motor control, proprioceptive awareness, and kinesthesia in a stable wrist. We know that isometric strengthening is useful for strengthening specific muscle without subjecting the painful and unstable wrist to a full range of motion, which could cause pain or noise. In the literature, good results of isometric exercises for pain management are reported. We encourage the patient to watch and palpate FUC and EVUC while squeezing a weight in slight supination and ulnar nervation. Then we increase time and weight. Eccentric exercises by wrist extensor have been shown to increase the co-activation pattern of wrist flexors, thus contributing to wrist stability. To perform eccentric strengthening of the extensor, a heavy weight is gripped while the wrist is slowly flexed, thus engaging the extensor as they lengthen. For the muscle shortening phase, the affected hand is used to lift the weight back into extension to start again. Reflexive muscle activation aims to restore the neuromuscular reflex patterns that exist in a normal joint and that are disturbed in a ligament-deficient joint. We use the slush pipe. This is the length of a PSC pipe, half filled with water, that the patient attempts to hold steady. Another RMA activities may be as simple as balancing hammer maple on a plate. As in this video, we use the plate design and 3D printed by us. We also use the paintball and the power ball. The power ball is a type of gyroscope using centrifugal forces to generate inertia, and those exercise the muscle acting on the wrist joint. The benefit on Powerball lies most likely in the multidirectional motion generated by the gyroscope, which demands a reflex activation of the wrist muscles and unconscious activation of both agonist and antagonist muscles. And finally, we did the plyometric exercises, which consisted of the initial throwing a ball with one hand toward the wall, catching it and quickly releasing it. As the patient progresses, every ball may be used. At the evaluation after 3 months, the patient had no more pain and rest, and she reported FAS3 under 3. Range of motion was complete and strength was also recovered. Thank you.
Now the last part from Dr. Guidi.
Okay, so at the very end of the day, I would like to thank you all, especially a lot of friends there online I saw as well Andrea Azzai connected, so the past president of the International Society of the Wrist, and so many therapists. Okay, so I would like just to sum up a little bit from a surgical point of view. I will keep it not too deep, and sometimes I will repeat some concepts that already were mentioned by my previous speakers. And what is the problem here? What is midcarpal instability? Right now, you know, it's a collective term for a problem that it's happening between the two rows of the wrist. But of course, for many years we didn't know, we didn't understand what is the real problem and who is the guilty guy in this pathology. So at the very beginning, so a long time ago in 1934, Moshe and Belot, they described a wrist that was snapping. It was like an instability, and they called it a snapping wrist. And then we needed to wait so many years, so the early 80s and the early 90s, where we could understand the real difference between the SID and the SIND. So the carpal instability dissociative, that it's an instability between bones of the same carpal row, and the SIND, so the carpal instability non-dissociative, where the problem is the entire row that it's not working properly. So in midcarpal instability, where is the problem? The problem is not the midcarpal joint. The problem is the proximal row. It's not working. And why it's not working properly? Because we can say it's an exception, because it doesn't have any attachment of tendons, and it's moving just thanks to the pressure that the distal row is generating during the movements. And as my previous colleague introduced, so we have 4 types, but it's important to say that the palmar midcarpal instability is the most frequent. And this will be as well my topic. Then we have a dorsal one, a combined one, and then in distal wrist fracture, we have an adaptative one. So it's more frequent than we think. So this is a palmar midcarpal instability. Patients are just telling us that they have a specific pain. They have some ulnar wrist pain. Sometimes they say that it gives way. But just if you ask them, they will say that the wrist clunks. But not all of them, they will tell us. And of course, there is some palmar subluxation that already my colleagues explained very well with the pictures. But which are the causes? So is there any injury in the ligament? No. The ligamentous laxity is the most common. Normally is so girls with hyperlaxity, they can remember some minor trauma, but it's important to say that in the ligament, we have some mechanoreceptor, the Ruffini receptor, the Golgi tendon-like receptor. They are working, just sending some tensile forces. So they are working with this tension information, and they bring information to our brain. So if the ligaments are attenuated or they are not working properly, these receptors are not working good. And of course, all the mechanisms that our cortex, our brain, is just trying to activate to counteract this instability are not working. So as well, muscle, tendons, they are not counteracting this instability. And of course, period of immobilization, this can lead to some loss of proprioception control with some attenuation of the ligaments. And of course, the triquetral amide capital ligaments, so the ulnar limb of the palmar arcuate ligament is the most important ligament that is attenuated in this pathology. Of course, as well, biomechanical studies showed that the dorsal radiotriquetral ligament is involved. And after the study of Mark Garcia Elias, we know that the SCT ligament as well plays a role in this pathology, as well as the scaphocapitate ligament. So what is very common in this pathology is this catch-up plank kinematics. So if you see from these drawings, as soon as we have an ulnarization of the hand, we have major pressure on the triquetrum, and then we have suddenly a snapping of the lunate that goes in extension. So it's thanks to the distal row that we have this problem. And of course, as well, in the lateral side, you can see this snapping during the radial and ulnarization of the wrist. So my colleagues showed very nice cases. I think this is a very easy to perform examination. This is the midcarpal drawer test, but was not validated for this pathology. And sometimes it's difficult to understand the grade of subluxation. And of course, it's done under fluoroscopy. And I think this is one technique that is really useful compared to the X-rays and to the MRI, because normally they are negative, they are normals. And we don't know, so we don't have a very clear injury there. That's why I say it's not a ligament injury, but it's more some attenuation or dysfunction of the ligament. And then this is the mediocarpal shift test, already explained, but I would like just to repeat it, because repeat helps everybody to improve in our clinical activities. So we can make some palmar subluxation of the midcarpal joint, and then we can try to elicitate it during the radial and ulnar deviation. Then, as my colleague said, volar sag is important. We have a subluxation of the wrist, and PCO published this distance, the piezostyloid distance, that it's really useful to measure. Sometimes it's so it's more clear. I love the drawings and video of Shrikant of these two lines, but in the coronal view. And we have different way to understand this palmar subluxation. And of course, this is one way. As already done, this is a grading severity. I don't like a lot the Lichtman classification, because I think, especially for beginners, it's difficult to understand what's minimal, moderate, or maximal subluxation. The difference between this grading is a little bit hard to find at the very beginning. That's why our Graves is English surgeon proposed this classification. So with a pre-symptomatic, so with no symptoms, and able to perform a catch-up plank. And these are patients that are at risk of symptoms. So we need to treat them, and as well, grade 1, that they are dynamic, and voluntary dynamic in grade 2. And the other two, as we say, the grade 3 and grade 4, they are static reducible and static irreducible, and we need to think about more surgical option. For conservative treatment, I don't have anything more to add after this universitary speak of my previous colleague. And of course, the cast immobilization, sometimes it's detrimental, and we have some so improvement, but temporary, just because of the attenuation of the ligament. And I think the therapist plays really a crucial role at the very beginning, and can really change the destiny of a lot of these patients. And I think that all the strengthening and the proprioceptive training of the piezotriquetral unit are crucial, are really important. And I loved as well all the tips that we saw in the previous lectures about the position of the hand and what to do. I really advise everybody to read the publication of Shrikant about how to build this splint, because it's really interesting, and it saves a couple of patients of me. So for the surgical treatment, R. Graves and his team published this capsular shrinkage arthroscopically done. So they were barning some point where the ligaments involved were possible to reach. And of course, they were not caramelized anything. They were just using the shrinkage. So they were barning these ligaments to make some contraction of the ligaments and some more tension. And they report very good results. Of course, in this technique, there are some critics, because if we are thinking about mechanoreceptors in the ligaments, and if we are barning them, of course, for just to make some shortening, we are always playing against the proprioception. And then for surgery, in the past, we have this reefing. So we have a shortening of the capsular part. The volar capsular reefing had a really high rate of failure. It was like 66% of failure reported by Lichtman. And the dorsal capsular reefing is still a good option. So if you see in the drawings, you can cut the dorsal and redundant capsule, and you can make a shortening of this. And in most of the cases, there are good results. Then Dr. Atzei, that is online with us, proposed with Hegert and Lucchetti this arthroscopic technique. And thank you, Andrea, for the picture, because it was sent today. I didn't find it a very good picture. And they report very good results. Of course, the number of patients, it's small, but it's promising. And recently, so this month, the group of the Institute of the Hand, so Institut de la Main in Paris, France, by Jean-Baptiste de Villeneuve-Barguemont, Matulin, Prenot, Merlini, and Mari, they reported another technique with an arthroscopic suture, palmary executed, with good results with mid to long terms. And then we have the ligamentoplasty. I was used to perform the Garcia Elias ligamentoplasty with the extensor carpi radialis brevis, and I still think it's a very nice operation, a little bit tricky. Of course, there is a huge scar, and probably sometimes even the scar is stabilizing the wrist, and we know. But of course, we are cutting as well a huge part of our dorsal ligaments, and we are losing more proprioception. And PCO as well, and Lichtman proposed other ligamentoplasty. Lichtman didn't have a lot of good experience with this, especially with the extensor carpi ulnaris rerouting. And then what it's in the last years more reported is the arthrodesis. So the partial fusions. So 4 cornea fusion has been reported to have good results, especially for pain. The trichotomate fusion as well with good results. And recently, so in the last 15 years, Marc Garcia Elias proposed the radiolunate fusion, if you see here, with good results, and eliminates the clunk. So I took this paper just to modify a little bit what we can do as algorithm of treatment. Of course, we had the experience of Shrikant, and we have so many proposals, but I think in symptomatic, pre-dynamic, and dynamic, we can do some conservative management. And you are crucial. So therapists are crucial in this part. And for a minimum of 3 months, you need to keep on strengthening the pisotricutal unit, the hypothenar muscle, the extensor carpi ulnaris, the flexor carpi ulnaris, and try, of course, to start in supination, because in pronation, if you use this little spinning ball or spinning instruments, you can develop some midcarpal instability. And if it fails, okay, we need to see if there is a reducible palmar midcarpal instability. And so we can do some soft tissue procedure. So we can eventually start with the arthroscopic capsule shrinkage or the arthroscopic open capsulodesis. We can do as well if the surgeon wants some ligament reconstruction. And in case of failure, we have already another solution, and it's the fusion of the wrist, the palmar fusion, that can bring, of course, some relief to the catch-up clank. I'll take a message. This is not a frequent diagnosis, and the diagnosis is tricky because so most of the time X-rays and MRI are negative. But please just try to see it and just try to advise your surgeon or your patient to be more conscious about this problem, because it's out there and it's more frequent than we think, especially from after a long period of immobilization. I thank you, and I invite you in Switzerland, in Lugano, in the Italian part. And I thank you, the team of Ergomano Rehab and Shrikant, to have shared this opportunity. Thank you very much.
Now we're in that part where questions comes, so we can answer it.
So I have a little burning question for Shrikant. Do you think that it's a good advice for maybe young therapists to start in supination and, of course, let the patient strengthen all the French muscle of the pisotricutal unit in supination, and then maybe after a period, because I saw you in phase 2 that you are doing as well some pronation of the end. Which is your advice for them?
So during our examination, we saw that quite a number of our patients did not have any catch-up clunk when the forearm was in supination. Then I gave an argument as to why we feel that there's no catch-up clunk when the forearm is supinated, because the carpus is realigned with, they're not sitting obliquely, but they're realigned with the distal radial ulnar joint. So I would always begin with forearm in supination and then strengthening and then transition to mid-prone. And I gave everybody as to why mid-prone transitioning from supination to pronation and then supination to mid-prone and then pronation is advisable based on our experience treating these individuals. So to all young therapists, I'll go on to mentioning that we begin with forearm in supinated position, then in neutral, and then pronation, because this transitioning is very important in order for the muscles to start regaining tolerance, strength, and coordinate with various group of muscles that are responsible for allowing you to go from radial deviation to ulnar deviation, and so on.
Perfect. Thank you.
I don't know whether you agree with me or not, but this is my personal experience, and one of my colleague, Joey Pipicelli, is in the audience as well, and he would agree with that. We actually took quite a number of our patients to fluoroscopy to evaluate and look at their stability with various kinds of splints, whether it be ulnar boost, whether it be the taping technique or other method. And we identified that the patients were a lot better in supinated position as compared to in pronation.
Thank you.
Thank you, Shrikant. There is
you.
another question for you.
Okay.
From Virus. I understand palmar instability is most common. Whether does the rehabilitation approach change if the patient presents with a different dorsal combined adaptive instability?
So let me see whether I can understand the question well. The person is asking me whether there is a dorsal instability and what would we do in the presence of dorsal instability. Am I correct? Is that the yeah, okay, that is it. So I think she's my colleague, ex-colleague from my institution as well. So we have treated few dorsal instability pattern, and again, in such situations, we found that whenever Sarah, whenever the person performed flexion of the wrist joint, the capitate popped out of lunate first. So it's capitolunate instability pattern. That's always on the dorsal side. So in such situations, quite a number of our patients were showing some deficit in terms of mobility, and then their pain was restrictive. So in such situations, patients require dorsal capsulodesis procedure, and we actually wrote a paper with my colleague Joey Pipicelli, who was sitting in the audience, about looking at how to manage the dorsal capsular plication in order for these patients to remain stable. So we treated these patients by means of a wrist hinge splint, not allowing these patients to go in excessive flexion. And of course, we had to retrain some of these muscles that were responsible for maintaining stability of the radiocarpal as well as midcarpal joint. But quite a few of our patients required this dorsal capsulodesis, and whom we treated by means of wrist hinge splint for lengthier periods of time following surgery until these patients have adequate amount of motion as well as strength. In some situations, of course, we identified that not necessarily everybody will have full range of motion. So I would recommend that not to go for achieving full range of motion in situations where there is a capsulodesis procedure or ligamentous plication and so on, because otherwise you may cause or reproduce the instability pattern if you are too aggressive and aggressively mobilizing this, attempting to gain full range of motion at the wrist joint. So in such situations, of course, you have to focus on gaining functional wrist range of motion.
And of course, if I permit, in adaptive instability, we need to correct the malunion of the radius, because if we, I think sometimes we see patients that have been treated conservatively for distal radius fracture with the dorsal metaphysis of the radius that is angulated dorsally, and this could lead with the time to palmar midcarpal instability. And in this case, I think that the treatment should be surgically. So we can do CT analysis with 3D printing instrumentation, and we can correct the malunion of the radius. And I think this is already indication for a surgery. So just to conclude the answer.
So in any situation where you have an adaptive instability caused by the extrinsic factors such as bony pathology of radius and line, as Dr. Guidi mentioned, that needs to be corrected first in order to resolve the instability pattern distally. Otherwise, you'll keep on battling with the situation, trying to recover radiocarpal orientation and midcarpal orientation.
Yeah, totally agree. Any other questions? Okay. Shrikant, do you have any cases that from your side, any other cases of your splint, or I mentioned that your publication, it's really important. Maybe maybe you can share a link, or because I think it's really cool when a therapist can build this splint with a in a
Right.
proper.
Yeah, so actually, I mean, I would like to point out here, me and Joey Pepicelli, my colleague from Roth McFarlane Hand and Upper Limb Center, we published a book chapter on carpal instabilities, and if anybody would like to have that book chapter, I'll be delighted to forward that as well, because it sort of has a detailed information in terms of carpal instability. I know that this type of a session doesn't allow us to go into the depth significantly. However, that book definitely deals with in-depth management of carpal instability. So, and I mean, in wrist in general is either over-treated or under-treated. And we have had a number of experiences where the patients ended up having limited motion in their radiocarpal as well as midcarpal joint post-operatively. So even though there is a carpal stabilization or carpal fixation, of course, we looked at the management somewhat differently. And in any given situation, wherever you can start patients on early controlled mobilization program, we always have done so by using wrist hinge splint. For example, somebody has scapholunate ligament repair, for example. Often patients are immobilized for a certain length of time, and often surgeons have a fear whether allowing these patients to start moving the wrist right away, then they'll probably have a failure of the ligamentous repair. However, we have used a special splints, as I showed some of the examples earlier. The wrist splint, we custom tailor the motion because motion stimulates healing, and there are some studies that have shown that motion is definitely advantageous in providing stability to the ligamentous structures because of increase in DNA contents, and of course the ligamentous structures definitely heal better with motion rather than with immobilization, because immobilization definitely causes poor vascularization, poor arterial flow, venous and lymphatic return, and because of deficiency in terms of hydration of the ligamentous structures that is caused by immobilization definitely gives us an adverse effect. So why not mobilize in a controlled manner? And intraoperatively, the surgeons can always find out the limitation in terms of motion that is permissible following surgery. For example, this patient that we treated with capitolunate instability pattern who required dorsal capsulodesis using a joint capsule attaching to the distal part of capitate, we identified that the surgical approach was on the dorsal side. So why limit these patients in terms of extension? We gave the patient a wrist hinge splint, allowed the patient to perform unrestricted extension. However, intraoperatively, and I was there at the time of surgery, I measured as to intraoperatively what is permissible flexion for these individuals. We custom tailored this motion, and ultimately the patient had almost full extension. Of course, we had to limit excessive flexion by controlling her range of motion. So intraoperatively, the surgeons can always measure the amount of motion permissible and share that with their therapist so that the therapist can custom tailor the rehabilitation in accordance with the surgical procedure that the patients have received.
Thank you. Thank you. So we have other comments made by Joy Pipicelli. Okay, I can share the carpal instability after. I think we can give the permission, of course. Thank you. So I think it was a really interesting webinar, especially for all the therapists that wants to manage this condition, that it's really not well known and not well so frequent. And I would like to thank you, Shrikant, for your time and for your expertise and for, I think as well, Ergomano Rehab. I thank you for the organization of this meeting. It was really an honor having you and having you like a giant of the hand therapy. And thank you for your time.
Thank you, and thank you, Marco, as well as the therapist from Ergomano Institute. So thank you for giving me this opportunity. And of course, since we have established contacts now, we can be frequently having a dialogue on different clinical conditions. I'll be delighted to be available to you and your questions. And same goes to Dr. Guidi as well.
Fantastic. Lovely. Thank you. Thank you.
Thank you.
Thank you.
I wish
Thank
you all
you.
a good evening. Thank you.
Bye.
Bye. Thank you.